Kadiwada. I'm one of the chief residents here at WashU. It's my pleasure today to introduce our speaker, Dr. Anitha Vijayan, this morning. Dr. Vijayan is professor of medicine in the Division of Nephrology here at WashU in St. Louis. Dr. Vijayan serves as the medical director of acute dialysis services here at Barnes-Jewish Hospital. Her clinical expertise and research have been primarily dedicated to improving outcomes in patients with acute injury. She is a member of the American Society of Nephrology's AKI Now Committee and the chair of the ASN COVID-19 Acute Kidney Care Committee. Today, she'll be discussing with us acute kidney injury and renal replacement therapy in COVID-19. Thank you for joining us this morning, Dr. Vijayan.
Good morning, everyone. Thank you, Ava, for inviting me. For the next 45 minutes, I would like to talk about AKI and renal replacement therapy in COVID-19 patients. And we'll also touch base on the experience at Barnes-Jewish Hospital as well. These are my disclosures, and maybe the only thing relevant for this talk might be the fact that I'm a consultant for Next Stage Medical. So for today's talk, we will cover the epidemiology of acute kidney injury, pathophysiology of AKI and COVID-19, and we'll talk about how we managed renal replacement therapy in the COVID-19 patient, but also touch on how we had to manage resources when we provided renal replacement therapy in the midst of a pandemic. I don't think I'll get to the patient with ESRD, so we'll focus mostly on patients with acute kidney injury for this talk. So let's start out with the case. So this is the first patient we were consulted on, nephrology was consulted on for a patient with COVID-19 and AKI. So this was on March 17th, 51-year-old African-American man with stage 3 chronic kidney disease. We don't know his exact baseline. He presented with syncope. Review systems were positive for fatigue, non-productive cough, fevers and chills, as well as diarrhea. He had not seen a physician in a long time, and so we did not have a baseline creatinine for him, but his admission serum creatinine was 7.1. He was admitted to the floor, and this is a time when, we were not actively isolating patients, but within 3 days, and the testing was not sent because they didn't have the usual risk factors for COVID-19 that we were asking for at that time. So within 3 days, he deteriorated. An ACT was called. He was intubated, transferred to the ICU with high O2 requirements. During this time, he became oliguric. His creatinine was up to 11.2. Potassium was 3.9. He was acidotic with a pH of 7.14. This is what his chest X-ray looked like at that time. And we'll come back to this patient later in my talk, but you can see how the X-ray has pretty impressive bilateral pulmonary infiltrates. So what do we know about acute kidney injury early on in the disease? COVID-19 first described in late 2019, and there were reports from Wuhan, China, about these patients, including, and what we wanted to focus on, which was the risk for acute kidney injury. And the reports varied widely, anywhere from 3% to maybe this report that suggested 29% of patients in the ICU had acute kidney injury. But it was a relatively small study. Now, there's also a paper that said, well, there was no AKI in these patients, and this paper has been widely criticized subsequently. But as you can see, the reports really varied widely on the incidence of acute kidney injury. And even from the outside the Wuhan and Hubei province, the reports really didn't give us much indication of what was to come, probably in the United States, and it was 0.5 to 17%. So later on, we started getting reports of acute kidney injury from United States, US, and UK as well. And so the first report came from Seattle, which reported a 19% incidence of AKI in the critically ill population. Similar numbers in England, Wales, and Northern Ireland as part of the ICU network there. And then there are 3 large studies that were published in the United States, 2 from New York and 1 from New Orleans. And they reported a very high incidence of acute kidney injury, especially in the critically ill population. And as you can see, high comorbidities included diabetes and hypertension. And we'll come back to this as to why this could be a difference between what we saw in China versus what we saw in the United States. So as expected, AKI was more likely to be seen in the ICU population over the floor population, general hospitalized patients. And also the need for dialysis was also much higher in the ICU population. Again, not different from what you would see with other patients. If you break it down further in the ICU, this is from Mount Sinai and Northwell, 800 patients, 1,300 patients in the ICU, 70% of them, almost 70% of them had AKI, and about 30% of them needed renal replacement therapy. So very high numbers, and similar numbers from New Orleans as well. As you know, these were the hotspots for COVID pandemic in the United States. And interestingly, when you look at where in the course of their hospital course that these patients were getting acute kidney injury, a significant number did present with AKI, but also you can see a spike after day 7, and this probably reflects their overall critical illness. But it was interesting that you can see the 2 spikes in when they developed acute kidney injury. So what were the factors associated with acute kidney injury? So in all the papers, you can see these factors: diabetes, older age, African-American population, cardiovascular disease, hypertension, obesity, and also mechanical ventilation. And I'll come back to that later on. So if you look at the US data versus data from China, the incidence of hypertension much higher, 60% versus 25%. Incidence of heart failure, CKD, diabetes. I shouldn't say incidence, these are underlying comorbidities that these patients had. And also US patients had higher numbers of respiratory failure as well. And there's talk about why this could be, maybe due to how ACE2 is expressed in different populations, but we're not exactly sure. And this could explain why we saw a much higher incidence of acute kidney injury in the US. So talking about mechanical ventilation, this is again data from the Northwell hospital system in New York. If any stage of AKI, either stage 1, 2, or 3, or those requiring renal replacement therapy, 89% of patients who needed mechanical ventilation had some form of acute kidney injury. And if you look at the patients who needed renal replacement therapy, if they're not on a ventilator, only 0.2% incidence of only 0.2% needed renal replacement therapy versus 23% of the patients who were on ventilator had renal replacement therapy. And interestingly, the timing of AKI coincided with time of intubation. The median was about 0.3 hours from time of intubation into onset of acute kidney injury. So what happens with mechanical ventilation? Well, there's a lot of hypotheses about, pulmonary hypertension, right ventricular dysfunction, venous congestion, maybe increased abdominal pressure, all activating the neurohormonal system and leading to decreased renal blood flow and renal perfusion. It is also possible that the same factors that are causing ARDS and leading to the mechanical ventilation could be the same factors causing inflammation in the kidney as well. But there's clear correlation between the need for mechanical ventilation and onset of acute kidney injury. So the Oxner group broke down the etiology of acute kidney injury in these patients, and hemodynamic instability appears to be a significant component of why these patients may develop AKI. And so tubular injury from ischemia, about 66%. There's also cases of rhabdomyolysis reported in COVID-19 across the US. And in this group, 7% of them had some form of toxic tubular injury. Unlikely to have interstitial nephritis, and there are also reports of glomerular disease, and I'll come back to the collapsing glomerulopathy later on in my talk. So we collected data from Barnes as part of this multi-center study called Stop COVID study of the treatment and outcomes in critically ill patients. It was 67 centers in US, and a huge thanks to my colleagues who were also participating in the study, Christina Joy, who just graduated, Ting Ting Lee, Seth Goldberg, and Patricia Cow. So it was a multi-center study. Of course, the hotspots were primarily New York. There was also Detroit and Chicago, sites from New Orleans. And then, of course, us. We had 50 patients in the study, and this is the data from Barnes. African Americans, 68% of the population. BMI was 30. And the comorbid conditions that we saw were almost 40% had diabetes and 80% had hypertension, and cardiovascular disease was also extremely common in these patients. The one lab value, a baseline lab value that stood out in these patients were the D dimer, extremely elevated in patients who died from the disease. And overall mortality in our center for the first 50 patients, 32%. 67% of these patients had acute kidney injury. Majority of them needed dialysis, so 50% needed dialysis of some sort. And death among patients who did not survive, the incidence of AKI was much higher, almost 87%. Among the survivors, the good news is that about 2/3 of them were able to come off dialysis, and we'll go back to that later. So again, mortality in patients who had COVID-19 associated acute kidney injury. If you look at the 3 large studies, patients with AKI, much higher mortality from those who, compared to those who didn't have AKI, anywhere from 35 to 50%. And this is the Stop COVID ICU trial. And again, the mortality was about 50% in the ICU if you had AKI, which is similar to other studies in non-COVID patients, and about 20% if you did not have AKI. And similarly, if you look at the stage of AKI, the worse the stage, the higher likelihood of death. So is SARS-CoV a culprit or a bystander when it comes to kidney disease? And this has been studied from the beginning, although initially it was very hard to get tissue because nobody wanted to biopsy these patients or even look at the look for SARS-CoV in the urine. So we all know how SARS-CoV affects or enters the cell. It requires ACE2, membrane-bound ACE2, along with the presence of transmembrane serine protease, which helps viral entry into the cell. And this has been shown to occur primarily in the lungs. This data is from Dr. Humphrey's lab here at WashU, and when you look for ACE2 in the kidney, it is expressed in the proximal tubules, but the TMPRSS is probably expressed more in the intercalated cells and less so in the proximal tubular cells. So it's still unclear how the virus enters renal cells. So the reports, kidney biopsy findings started being reported in probably July. And so this is from Columbia, where they had 17 patients with COVID-19, 14 native kidney biopsies were performed. And the indications for biopsy was acute kidney injury in 88%, and 53% of the patients also had nephrotic range proteinuria. So if you look at the results, collapsing glomerulopathy was noted in 6 of the patients. There's also evidence of acute tubular injury and other immune-mediated glomerular disease, but there's no definite detection of virus in the kidney in this study. So what do I mean by collapsing glomerulopathy? So this is where the glomerular tuft completely gets damaged by, primarily mediated through damage to the podocytes. And you can see there's a foot process effacement. And also what they found was tubular reticular inclusions in the cells. And this is very reminiscent of other viral podocytopathies, especially HIV nephropathy, which causes a very similar picture in the kidney. This is also another study looking at collapsing glomerulopathy and showing evidence of tubular reticular bodies in the glomerulus. Other studies were also done looking at kidney biopsy specimens. Patients had varying degrees of ATN. TMA was noted, and myoglobin Cas nephropathy was also noted in these patients. But again, SARS-CoV particles could not be identified in this biopsy specimen. Researchers also did postmortem analysis. This was one of the first postmortem reports out of China, and there's extensive tubular injury in these patients, along with the presence of TMA. And if you look at all the 26 cases, all had some evidence of tubular injury. There was evidence of fibrin thrombus in the glomerulus, and there's also evidence of viral particles with some SARS-CoV nuclear protein present in some of these cases. And this is how they showed the viral particles. You can see what looks like viral particles with possibility, the corona-like appearance, the crown-like appearance of the coronavirus. Of course, there's always a rebuttal to anything. And so interesting titles in these letters to the editor: not all crowns are coronas, and am I a coronavirus? And basically what the authors pointed out was these particles could actually be clathrin-coated pits, which are found in normal kidney tissue and also vesicles. And so they basically said this doesn't prove that you have evidence of a coronavirus in the kidney. So 2 recent papers from Toby Huber's group in Germany actually now gives us much more evidence of renal tropism of SARS-CoV-2. And he was able to localize SARS-CoV protein by in situ hybridization and immunofluorescence in the renal tissue. And more recently, this is just published 2 weeks ago in Lancet, he was able to actually homogenize the renal tissue and then subsequently put the homogenase with primate cells and basic tubular cells, and essentially, show that coronavirus particles can be amplified within 2 days. And this seemed to correlate with outcomes, the clinical course, including survival. And he was able to document this more so with patients with acute kidney injury, thus suggesting that SARS-CoV may actually have an impact on outcome of the SARS-CoV tropism of the kidney may have an impact on patient outcomes. So to summarize this section, I just want to say AKI may be mediated by other factors than direct viral involvement, including hemodynamic instability of these patients in the setting of critical illness, nephrotoxins, rhabdomyolysis, microvascular thrombosis. But renal tropism may correlate with clinical outcomes, at least documented in 1 study. And viral involvement of the kidney may not necessarily lead to tubular injury, but probably may lead to podocytopathies and glomerulonephritis. We recently had a patient who had just recovered from SARS-CoV a month out, and she presented with 18 grams of protein. We biopsied her, and she had collapsing glomerulonephritis or glomerulonephropathy. So once AKI occurs, how do we manage these patients? And so again, we go back to our first patient, right? So this is what the chest x-ray looked like. Remember, the patient was acidotic and was intubated. So at this time, nephrologists were not going into the rooms to examine these patients. We were relying on our ICU colleagues to give us information on volume status. And we're also basing our evaluation on chest x-ray and lab values as well. So essentially, the management boiled down to, well, we don't want to aggressively diurese these patients. This may exacerbate their volume depletion and worsen renal function, but we also did not want to aggressively fluid resuscitate these patients as well, right? When they were very hypoxic, even though they could be potentially volume down. So what we recommended was if we're going to use volume resuscitation, we recommended balanced crystalloids over normal saline. Studies have shown that this decreases the risk for acute kidney injury. And also, if the patients were volume overloaded, then a trial of high-dose loop diuretics, we recommended that prior to starting dialysis, primarily because we started having shortage issues, which I'll address later. For hyperkalemia, we have the option of giving sodium zirconium cyclosilicate. We do not use Kayexalate in the hospital anymore, and we recommend this over patiromer, which is the other potassium binder, because the onset of action is 1 hour, and we can potentially delay dialysis until the COVID results were back. We also recommended use of bicarbonate, primarily based on this bicarb trial, which showed that IV bicarbonate can potentially delay the need for dialysis and also decrease the risk for needing dialysis during the ICU stay. So we did, recommend these three: fluid management, management of hyperkalemia, and metabolic acidosis prior to considering renal replacement therapy. And basically, if they are not responding to medical management, we will initiate renal replacement therapy if the patient was deemed a suitable candidate. So when we talk about renal replacement therapy for any disease, we usually talk about timing, dose, and modality. When do we start renal replacement therapy? What's the dose, appropriate dose of therapy, and what modality should we be using for patients? And I would say for the most part, things were no different for the COVID patients, but I just wanted to revisit these issues. So we always joke about this, that this is a fellow who left a few years ago during the roast for the attendings. He basically said, from Dr. Vijayan, I learned to dialyze first and ask questions later. And from Dr. M, I learned never to start dialysis. And as you know, when you talk to nephrology about timing of initiation of renal replacement therapy, we probably have a wide variety of opinions on when to start. This study happened to be published in the middle of the pandemic. This was not a COVID-19 related study, but this is the largest study ever to address initiation of renal replacement therapy. It was a multinational, pragmatic, open label, randomized controlled trial. It was just published in the New England Journal last month. And basically, they were randomized to starting renal replacement therapy within 12 hours of reaching criteria, which is doubling of serum creatinine from baseline, or urine output less than 6 ml per kg per hour, 6 ml per kg for the preceding 12 hours. And these are in adult patients in the ICU. In the standard arm, a renal replacement therapy was not started unless they were hyperkalemic, K of 6, acidotic, pH of 7.2, or bicarb of 12, volume overloaded or hypoxic, or they had persistent acute kidney injury for 72 hours. And I think this is something that we, as nephrologists, seem to forget, because persistent AKI may also have, adverse outcomes. And so just because there are no other indications, we should be considering renal replacement therapy if they have persistent acute kidney injury. And there was no difference in survival between the two groups. And if you break it down further into, if we look at the adverse events were significantly higher in patients started earlier, especially hypotension and hypophosphatemia. So definitely our strategy for starting renal replacement therapy should be closer to the standard arm of START AKI, which is what I just described. But also, other factors like did they have any toxic ingestion? What about practical points like, who's available to place a catheter or start dialysis, the nursing personnel to start dialysis. And also, they did not do a subgroup analysis on oliguric patients, but oliguric and anuric patients tend to have worse outcomes. And so they may need earlier initiation, since they're the ones who can potentially deteriorate rapidly within a few hours. So what about dose of renal replacement therapy? If you're going to do intermittent hemodialysis, we track urea reduction ratio, and we make sure we provide intermittent hemodialysis 3 times a week with a urea reduction ratio of about 70%. And if we're using continuous renal replacement therapy, the flow rates that we recommend are 20 to 25 mils per kg per hour. Sorry, this is mils per kg per hour. And I'll come back to this flow rates later when we talk about how we manage resources during the pandemic. So modality, as you know, we have several types of dialysis treatments available. Hemodialysis is our standard, primarily reserved for stable patients. We have different forms of continuous renal replacement therapy. We also have a hybrid form called prolonged intermittent renal replacement therapy, which we call SLED here at Barnes. And then peritoneal dialysis, you may not be that familiar with PD, but PD is used for AKI in developing countries, but not so much in the United States in the adult population. But again, we'll talk about PD in the midst of the pandemic. So KDIGO, kidney disease improving outcomes, basically recommends that we use either continuous or intermittent renal replacement therapy as complementary therapies. But in hemodynamically unstable patients, CRRT is recommended, especially if they have acute brain injury or increased intracranial pressure. So if you look at what the machines we have available at Barnes, you're familiar with the Prismaflex and the Next Stage machines. And this is what we primarily use for our patients with COVID-19. But we did tend to use more Next Stage because the nurses didn't have to go into the room as much to change bags for this machine. PERT or SLED, like I said, we have used this at Barnes for over 10 years. But the advantage of doing this is basically you can take one CRRT machine and use higher flows. So basically take the 20 mLs per kg per hour and divide the total number of fluid for 24 hours by the hours of treatment. And you can use one CRRT machine for up to 2 or 3 patients with cleaning in between if you shorten the duration of treatment. This practice had to be implemented in other centers in the midst of the pandemic because they just did not have enough CRRT machines to handle the patient load. But like I said, we were already doing this at Barnes for 10 years, so it wasn't a practice change for us. And again, we use this Next Stage machine to do our PERT treatments. The one thing that took all of nephrology by surprise was the hypercoagulability of these patients. And I'm not going into the details of why they were hypercoagulable. I'm sure the hematologists have already described this in great detail, but there's various factors involved in hypercoagulability in COVID-19 patients. And if you look at the incidence of DVT and PE, it was fairly high. It was anywhere from 8% to as high as 35% incidence of PE in the study from Netherlands. So extremely high incidence of clotting. And this affected us because our machines will clot, and we were trying to avoid blood loss for the patient, and B, save the filters. So we were using heparin. With the Prismaflex machine, you can give heparin through the machine itself, but with the Next Stage, we needed an external pump anyway, and so we asked the intensivist to start all these patients. Anybody we were starting on CRRT, we requested that they start IV heparin systemically as well. Citrate anticoagulation is also possible. And again, this is something that we have already available at Barnes. And we were able to administer citrate anticoagulation with the Prismaflex machine during this crisis. And of course, citrate protocol is extremely time intensive. And there's a huge concern for safety events because if you don't monitor the calcium properly, patients can get into trouble. And they're also at risk for metabolic alkalosis and other issues as well. So we monitor the ionized calcium both from the patient and the machine very closely, and we have protocols in place for this already. So our plan was we will start the patient either on systemic heparin. Actually, most of our patients ended up on systemic heparin because the intensivists decide to start anticoagulating these patients anyway. But if heparin was not possible, we were using regional citrate anticoagulation with the Prismaflex. And if filter clotting persists, we added heparin on top of the citrate anticoagulation if possible. And if unable to maintain filter patency, we asked the intensivist to help us by adding other potential agents like direct thrombin inhibitors. So anticoagulation became essential for patients on CRRT. And what I recommended other institutions was basically use the protocol that we have, what you have, because citrate protocols, if hastily implemented, can lead to pretty serious adverse events. So what were the issues that we had to address when we were providing renal replacement therapy during the pandemic? So the first was managing PPE, right? So we had a huge PPE shortage, if you remember, in March and April. And so if we're waiting for a patient COVID results to come back, we will try to delay renal replacement therapy if at all possible. So we will use diuretics, we will use the K binders, we'll use bicarbonate to try and delay dialysis. Our nurses became extremely overwhelmed with the number of patients we had. So the fellows and nephrologists got trained on setting up RT equipment. Thankfully, we didn't have to do it, but they also got other nurses from other areas, from say orthopedics or Shukar, where they had nurses who were probably not having any patients to take care of, and they formed a buddy system so they could monitor more patients. Other centers use perfusionists to try and set up CRRT machines. And our primary goal was to reduce exposure to the virus for the both ICU and dialysis nurses. So the other things that the ICU nurses started doing, and this is from our ICU, is they put the CRRT machine outside. So this machine is connected to the ECMO circuit, and they didn't have to go in as frequently to change the bags. And also the effluent bag, which is the bag they have to drain every 2-3 hours. This nurse, who was very creative, actually hung it on an IV pole and let it drain back into the sink in the room. But anytime these maneuvers were tried in other centers, we always recommend patient safety first, right? So in this center from UAB, they use extension tubing to put this machine outside, but with extension tubing, you risk exsanguination as well as hypothermia. And this is also from St. Luke's Hospital, where the hemodialysis machine was kept outside because the bed was closed. Bed was pulled close to the door, but again, the door is not very tightly closed, so this also increases exposure. The other thing was ensuring appropriate anticoagulation, as I discussed before, because we wanted to maximize the filter life. A filter for the CRRT is meant to last anywhere from 48 to 72 hours. We were running short on filters at some points, and so we really wanted to make sure these patients were anticoagulated to preserve filter life. Once the patients were stable on continuous renal replacement therapy, we did consider reducing their flow rates from 20 to 15 ml per kg per hour. So a huge, significant reduction in flow rates, because we did start having shortages of fluids as well. And like I said, we were using CRRT machines here anyway to do per treatments. There were also talk about alternative fluids to commercial bicarbonate CRRT solutions. So if our bicarbonate solutions for CRRT comes through the pharmacy, it's purchased from companies, and basically consist of bicarbonate solutions with appropriate amounts of electrolytes. Well, again, there was a nationwide shortage of bicarbonate solutions. So we were asked to switch to lactate solutions, which is what we use for home hemodialysis patients. So right now, because of shortage of bicarbonate, we have to use lactate solutions for certain patients who are hemodynamically stable. If they don't have significant hepatic dysfunction or immediately post-transplant, if they don't have, as I said, severe hemodynamic instability or lactic acidosis. So there's still an ongoing shortage of bicarbonate solutions in the US. Other centers got even more creative. They started making their own bicarbonate solutions in the hemodialysis unit. If you remember the hemodialysis machine, that's what it does. It generates bicarbonate to dialyze the patients against, right? So basically Hopkins and Cleveland Clinic started this trend where they used hemodialysis machines to create bicarbonate solutions, which they then collected in bags. The problem with this is these bags are not big enough. We don't have 5-liter bags available in the United States to collect these fluid, and but it was done in centers, including Columbia, in the time during times of surge. Of course, this cannot be used as an infusate, so you can only use it as a dialysate for CVVHD and not for CVVH. Oops. The other thing that centers in New York, Texas, New Orleans did was start doing acute peritoneal dialysis. We did not have to do this at Barnes-Jewish Hospital, but essentially surgeons and interventional radiologists were placing PD catheters, sometimes at the bedside, sometimes taking them to the radiology suite. And these are the cyclers that were getting ready for, physicians were getting ready to start the patients on acute PD. The problem with peritoneal dialysis is that it's not recommended in the setting of high PEEP. You cannot use it in patients who are prone, and also you cannot regulate volume removal with acute peritoneal dialysis. And again, we had a plan in place in case we had a surge here, but we did not have to do acute PD at Barnes. So as you know, in the US, the government really ramped up production of ventilators, but dialysis was not addressed at all on a national level or at a federal level. And so this story really struck me. This story was from New York Times, and basically tells the story about this patient who was in the ICU with AKI, became hyperkalemic. So he received his first dialysis on April 7th. This was a Tuesday. Ordinarily, somebody like this would have been on continuous renal replacement therapy. Subsequent treatment was not till April 10th, so 3 days later. And then I think the doctors started recommending that he receive peritoneal dialysis, probably because they did not have enough machines for CRT machines. And so basically on April 14th, his potassium went up to 7.2. He did have the PD catheter placed at that time, but unfortunately, even after they started PD, he ended up passing away. And this really struck me because I feel that, of course, there may be parts of the story that we're not aware of, but I really feel like if we did not have the surge, we may be able to do CRT on this patient, and he may not have passed away. So this report goes on to talk about doctors and working 18 hours a day. A lot of the dialysis nurses were out with COVID themselves, and I've heard this reports from other physicians in New York as well. And also this tweet from a doctor in Mount Sinai, it's like hemodialysis is like an auction, K of 6, it's 6.5, sold to K of 7. And this is how they were determining, who gets dialysis. So definitely there was a shortage of dialysis equipment, dialysis nurses, and dialysis solutions. And I think this needs to be addressed in the future. Luckily, at Barnes and BJC, we did not face the same amount of same volume that New York faced. And we were able to treat everybody with the equipment that we had. We had to buy 6 machines urgently. We had to share bicarbonate fluids among the BJC hospitals, but overall, we were fortunate in that we did not have to go through what New York hospitals had to go through. So going back to our patient, like I said, he was intubated on 320. Renal replacement therapy was started on 320, similar to the papers that we just reviewed. He was extubated on 4/8. He never recovered renal function, so he had a tunnel catheter placed on April 22nd, discharged to rehab, and now he comes for outpatient dialysis at Chromolytic Kidney Center. I have to say majority of the patients did recover renal function, so he was an exception. So to summarize, COVID-19 is associated with high incidence of acute kidney injury, especially in the critically ill patients. It's most likely due to ischemic and toxic tubular injury, especially in patients on a ventilator. But it should be noted that SARS-CoV-2 has been detected in renal tissue and can potentially cause podocytopathy and glomerular disease, and even maybe a contributing factor to the tubular injury as well. Providing renal replacement therapy to patients with COVID-19 during the surge was very challenging for various reasons that I explained already, primarily exposure of staff to the virus, shortage of PPE early on, and again, RRT resources are limited. Like I said, there's no federal stockpile. There was no federal stockpile of dialysis machines, but I heard that's changing now. They will start stocking some machines for the future. And I have to say, collaboration, planning, and management resources were extremely necessary to make sure that every patient who's deemed a suitable candidate for RRT will get that treatment that they need. I'd like to thank, first of all the folks in my division. So this is the fellows graduating for last year. They really, pitched in to help during this time. But we try to protect the fellows as much as possible during the pandemic. So the nephrologists were the ones, attending nephrologists were the ones who took care of COVID patients. Dr. Humphreys, huge thank to Dr. Humphreys as well. And also a shout out to the women in our division. This is us celebrating Monica's paper prior to the pandemic. So huge support. And this is the Women in Medicine Month. So shout out to my colleagues as well. So thank you, everyone.
Thank you, Dr. Vijayan, for that wonderful talk. We can now move on to the question and answer portion of Grand Rounds. Feel free to send questions our way through the question and answer tool at the bottom, or you can utilize the chat as well. To get us started here, you mentioned that that initial patient that we saw here at Barnes-Jewish Hospital who needed dialysis for his acute kidney injury did not recover his kidney function, and this seemed to be more so the exception. Does it seem that these patients recover their kidney function more so than our patients that are typically seen with critical illness?
I would say no, it's probably about the same. So based on previous trials like ATN study, the survivors tend to recover renal function. About 75% of survivors tend to recover renal function. So the data from Barnes showed about 65% of the initial 50 patients recovered renal function. So maybe slightly lower just on that one analysis that we did here, but I would say it's probably the same. This patient probably did not recover, probably because he had significant underlying CKD that we weren't aware of.
Yes, I remember you mentioned that he had that CKD with an unknown baseline. Another question we have here is, how much would you expect a serum lactate to increase if you're using this lactate dialysate solution?
So that's a good question, and I'm not sure if we have clear data for that. And I don't think it's going to go up by 1, maybe 0.5, 0.6, but it could be worse in the setting of hepatic dysfunction and in patients who are already hemodynamically unstable. But we don't have clear data on exactly how much it will go up by.
Okay, thank you for that. And you mentioned at the beginning of your talk that you wouldn't touch too much on patients with ESRD and this COVID epidemic. In relation to that, for patients who are receiving dialysis Tuesday, Thursday, Saturday, or their schedule, were any of them able to transition to dialysis at home, or can you just touch upon some of the things that you guys had to implement in your dialysis centers to keep your patients and staff safe?
Thank you so much for that question, because, as you know, during the pandemic, most elective procedures were canceled or postponed. Well, dialysis is not, elective at all. So we really had to change a lot around our ESRD facilities, and a huge thanks to the ID team for helping us with that. But basically our screening process changed. We had to discuss transportation issues and how these patients are being transported from nursing homes. As you know, nursing homes were heavily affected. A lot of our dialysis patients come from nursing homes. So we had to work with transportation companies, nursing homes, the major dialysis chains in figuring out how to transport these patients safely. We also had to make sure that we had shifts reserved for COVID patients, like COVID PUIs and COVID positive patients. So we try to cohort them to the third shift. And yeah, there were so many things that we had to address. The ER was pretty good about screening these patients. If an ESRD patient did go to the emergency room with vague symptoms, they were being screened early on for COVID. They were considered high risk, and which they turn out to be. So.
Yeah, it sounds like it was quite the endeavor a couple of months ago. And you guys did a great job taking care of our patients here. And then you had mentioned that the lactate dialysate is something that was used for patients on home HD. I'm not super aware of home HD being an option for our patients with ESRD. Can you talk a little bit more about that, shifting gears a little bit?
Sure. Yeah. So home hemodialysis, our home hemo program is one of the largest in the country. And we started this 20 years ago. Dr. Bren Miller and now Dr. Mitneja and Dr. Mehdi Reddy leads that program. And basically, it's a huge advantage for patients who are very independent and who wants to stay at home and not go to a center 3 times a week. And so we started out by using the larger HD equipment, but they had to remodel their plumbing to accommodate, make sure they have adequate water. But now we can use bagged solutions in the next stage machines for home hemodialysis. That's been going on for 10, 15 years. And so the primary solution they use is lactate based, and it works well for them because they don't have any hemodynamic instability. They don't have liver dysfunction or any other problems, and they do well with that.
Okay, thank you for sharing that. I think we'll conclude the question and answer portion for now. Thank you for sharing your work as well as the work of your department the last 6 months and even beyond that. If anyone has any follow-up questions for Dr. Vijayan, feel free to send them my way. My name is Ava Kadiwada. You can also feel free to reach out to her as well, and I'm sure she'd be more than happy to respond to your questions. I will share my screen in order to give you all QR codes for credit for CME mock as well as for our residents here. Thank you, everyone.